Good afternoon, everyone. We're going to go ahead and get started. Thank you all for coming. So we have two different separate presentations, First, we're going to hear about some research that's happening in the substance use, substance treatment, recovery area, how to support some families, some tools, and then we're going to hear directly from a provider and a parent partner with that provider agency. So we're going to go ahead and get started. So first, we have Dr. Joanna Falk. She is a licensed clinical psychologist and assistant professor in the Department of Psychiatry and Behavioral Sciences at UC San Francisco. Dr. Falk has a PhD in clinical psychology from George Mason University and completed her pre-doctoral clinical internship at UC Davis Medical Center. She works at UCSF Juvenile Justice Behavioral Health Lab, which aims to improve behavioral health outcomes for youth and families referred to the juvenile justice system. I never knew there was a juvenile justice behavioral health lab, so that is way cool. Just a little side note. Okay, I'll stop. And then we also have Dr. Evan Holloway. He is a clinical psychologist and postdoctoral fellow in the NIDA T32 traineeship in substance use disorders treatment and services research in the Department of Psychiatry and Behavioral Health and Behavioral Sciences at UCSF. Dr. Holloway received his PhD in clinical psychology from Fordham University and completed his pre- and postdoctoral research fellowship through the clinical psychology training program at UCSF. So welcome, Drs. Falk and Holloway, and I'll go ahead and let you all get going.
Thanks, Kathy.
Hello, everyone. Thank you for welcoming us today and for attending our talk. So our talk is going to be broadly on addressing substance use among justice-involved youth, and just acknowledging my co-author, Joe, will be speaking, and also our co-author and leader, Dr. Tulu Shams, who could not make it today. We have no conflicts of interest to disclose. Just want to highlight that funding for this work comes from the National Institute on Drug Abuse, the Visa Foundation, and the American Psychology Law Society, as well as the T32, that funds my salary. And we just want to thank all of the youth, families, and our system partners who have helped make this work possible. We literally could not do it without a team, with our internal team, and a lot of collaboration and partnership. So thank you so much.
All right, so we work with a group called the Juvenile Justice Behavioral Health Lab. We're at UC San Francisco, and our mission really is to improve the quality of care for youth impacted by the juvenile justice system and the foster care system in terms of both mental health and substance use treatment. And a lot of our work leverages technology to do this, and we'll talk about a number of the studies that we're doing. But really central to our work is treating youth and families as the experts that they are. So they know what they need, and we need to listen to them and involve them in the work. And so all of the work that we do is in partnership with community. So I know that you heard a little bit about who we are, but just to give a little bit of background on both Evan and I. So I did my training in psychology actually in Virginia. So I'm originally from the East Coast, was working with families who had incarcerated parents. So with kids in the community who had mothers in jail specifically. From there, I started working with youth in juvenile hall as part of my clinical training. So spent time working in juvenile hall and then also in a less secure shelter placement that was for youth who had been charged with status offenses. So from there, within clinical psychology, for those who don't know, they end up moving you around a lot throughout training. So I came out and actually lived in Sacramento here for a year and did a lot of work in YDF and with youth on probation, and then ended up in San Francisco. So really have a lot of direct experience serving youth and families impacted by the legal system, and that's really driven my passion for the work. Evan.
Thanks, Joe. Similar to Joe, before I started grad school, I got really interested in kids who were involved in the juvenile justice system in college. I did an AmeriCorps term and worked at a juvenile correctional facility for all sex offenders. I had a lot of ideas about what that meant as a 19-year-old myself, but that got me really interested in juvenile justice. And then after that, I worked in the community with kids who, as a crisis manager, so kids with chronic runaway behavior, and worked a lot with probation officers. So that's where I got really interested in probation, and that led me to, we did some research on probation in the state of Indiana, and then also done research on probation and risk assessment in Connecticut and in Pennsylvania as well, before I came to San Francisco for an internship. All right. So just to highlight the objectives of our talk today, and again, we hope this can be a conversation, so as you're listening, if you have questions, feel free to raise a hand or write down on the cards, and we hope, we just want this to be as helpful as possible. But our plan is to identify barriers to behavioral health service access for justice-involved youth, to understand what are the key principles of effective substance use treatment for justice-involved youth, to highlight ongoing some, clinical research projects that we have, specifically using technology to improve access to treatment and associated health outcomes for kids in foster care and in juvenile justice. So just to highlight, some of these might be, known, but I think it's really important to talk about the needs among kids in the juvenile justice system. So there's a very high level of behavioral health needs for kids who come into contact with the system. However, most do not receive the treatment that they need. So some estimate, these are just some broad estimates, and it can differ from kids at the first level, first contact, all the way through to detention or incarceration. But broadly, 1 out of every 7 kids in the justice system receive mental health treatment who need it, and about 1 out of every 10 youth who need substance use treatment actually receive that. And so, one would think that being detained, for example, right, might help improve access because you're there in the facility, but we see that about 15% of detained youth who need services receive it, and then that goes down to about 8% once kids return to the community. We also, because there's a big focus, right, this conference on kids placed in foster care who are in juvenile justice as well, just wanted to highlight some, that kids who start in the juvenile justice system and go to the child welfare system are especially high risk. They have higher rates of recidivism, and some research has shown that especially substance use, peer deviancy, and problems in school and education are some of the strongest predictors of recidivism. Again, because of the focus of this conference, just wanted to highlight, some of what we know about kids who are dually involved. And as you all know, right, there's a lot of jurisdiction differences. But this data came from an OJJDP report that looked at, I think it was 3 jurisdictions, different places in the country, and kind of mapped out all the different ways that kids could become dually involved. And so to highlight, most kids, this kind of, this 58%, this biggest piece of the pie, most kids who become dually involved are involved in child welfare first, then they'll have their case closed, and then at some point in the future become involved in the juvenile justice system. And you can see the second most common is when kids are starting child welfare, their case does not close, and then they continue into the juvenile justice system. But as you can see, there's a heterogeneous population, and there's a lot of different ways that kids can become dually involved. Excuse me. Also want to highlight that about half of kids in juvenile justice have a history of child welfare involvement. However, most kids in child welfare don't enter into the juvenile justice system. And among kids who are dually involved, we see that Black and female identified youth are more likely to become dually involved. Okay, so what do we know about treatment and what actually works? So these are from a meta-analysis, which is our fancy research way of saying a bunch of studies put together to sort of look at the effects, not just from one study, but when we combine them, what are the effects? And so I want to highlight, if you look at this sort of bottom left part, that there are some interventions that actually cause problems. So interventions that are focused on discipline actually can increase recidivism risk, as well as deterrence, can either have no effect or can actually also increase the risk of recidivism. And so it's also really important to highlight that kids who, these interventions are most effective with kids who are deemed high risk, like on a risk assessment instrument or something like that, and that most kids who are low risk actually are going to be better off with minimal contact. And this is supported by the risk needs responsivity model and a lot of the research that comes out of that. However, so when kids do get involved in treatment, there are some things that really work. So surveillance can be helpful, right? Monitoring, but want to highlight restorative justice approaches, skill building, counseling, and some combination of those are effective in reducing recidivism. So that's the good news. In terms of the different modalities, want to kind of highlight in the upper right, there are also a lot of different modalities that can be effective. Right.
And so in part, we're sharing this information with you so you can continue to be informed consumers when you hear about a young person you're working with being referred to treatment, or you hear about approaches that providers are taking. We want you to know what's actually evidence-based, what is known to be effective. And so for adolescent substance use treatment, there are really like 10 broad principles of what makes up effective adolescent substance use treatment. And I know it's a little bit small up here, so for those in the back, the key ones that you want to look out for. So it's really important that kids are getting a thorough assessment of their needs. So in terms of understanding what substances they're using, how frequently, but then also the factors that are at play in their life that might be contributing to use. So understanding things about their family background, understanding trauma history. So really getting just a comprehensive picture of them is really important to inform what the treatment plan is, right? Because if we don't know what's going on, we don't know how to effectively intervene. So programs should also be comprehensive in addressing all these different areas of need for teens. So if we just target kind of one specific factor, we're not going to be able to make holistic changes for a young person. It's the same thing if you just pluck a kid out of their environment, give them a little bit of therapy, and then stick them back in it without addressing anything within the family. It's probably not going to go well, right? And I'm sure you've all seen that. So actually family involvement in treatment is really crucial. And this can look really different for kids who are in foster care, right? There are complex family needs at play. So this might be family of origin. This is also then the family who's caring for them. So maybe it's kinship caregivers. So maybe it's grandma who's entrusted with care. But then also within the foster parents, right? It's a home environment. So making sure whoever is helping to care for this child is actively involved in treatment. So developmentally appropriate programs are really crucial, right? So there's a reason why we have a different child mental health system than an adult one, because kids are still developing, their brains are developing, they just have different needs. So you want to make sure it's developmentally appropriate care. Engaging and keeping teens in treatment, so actually building a trusting environment within a therapeutic relationship, right? And this is not even just substance use specific. This is just good practice in general. And you know this, you need to build a relationship with a young person for them to be even willing to open up with you and trust anything you have to say. Having qualified staff, so making sure that staff are actually trained in adolescent development, also in co-occurring mental health and substance use needs, right? Because substance use doesn't occur in a vacuum for a young person. Making sure that they have some level of competence in terms of gender responsive factors, culturally responsive factors, so treating the youth again as a whole, understanding where they come from. Also that it's continuing care, so you want to make sure that there's talk about relapse prevention right from the get-go, right? We're not just treating this one instance of what's happening, thinking about the youth over time and what skills do they need to be successful in maintaining, if it's abstinence from use or whatever the goal is there. And then actually having a measurement of the treatment outcomes. So making sure that there's a specific goal of treatment and that it's being measured and the youth can see that success and have something to hang on to. And the other one that's not captured on its own up here is really that you have to treat co-occurring mental health needs. If you don't address mental health, it's really hard to address substance use. Our systems are really siloed, right? We have different medical systems. We have different providers who are qualified to treat mental health and substance use, but these things do go together. And there are a lot of different reasons why teens will use substances. Sometimes it's self-medication, sometimes it's not, right? So this idea of trying to kind of numb out or not deal with whatever you're feeling. Kids use for a lot of reasons. It's important to understand why that is and then address that root cause of it. A really useful resource if you're not familiar with this, has anyone ever seen this California Evidence-Based Clearinghouse for Child Welfare database? Okay, I see a few head nods. So this is really helpful just to actually inform yourself about different treatment practices that the young people that you're serving might be participating in. So you can go to this website, it's at the bottom there, and you can actually type in a treatment approach that you have heard of or that a young person that you're working with is receiving. And then you can see what the evidence is to support that practice. So is that actually an evidence-based practice? What youth has it been evaluated with? Where is it inappropriate? And what do systems then need to consider if they actually want to implement a new practice in their jurisdiction? So I'd encourage you to take a look when you can.
Awesome. All right, so let's say you found an evidence-based practice, or you already have one, right, and you're working to implement it. Just want to highlight that there's still ways to go, right, to make sure that families are getting the help that they need and for the identified treatment needs. So first want to highlight that getting into treatment and the evidence-based practice, there can be a lot of barriers, right? There are a lot of disparities in access, who gets referred. We have seen that white kids are more likely to get referred to treatment versus kids of color, for example. There's a lot of racial disparities in the juvenile justice system, as we know. Also, perceptions of the system, right, and trust. Talking about things that have been, going on in the family, trauma, and prior experiences with the system can also be barriers to engagement, as well as stigma about mental health and substance use. And then I'm going to talk about in the next slide some of the implementation challenges and how to think about those as you look to adopt some of these practices in your jurisdiction. But I want to highlight some of the research that we've looked at in terms of barriers to treatment among families who are justice involved. So these are caregivers endorsed a number of different challenges, including transportation issues, getting to appointments, right? And the more services that their kid is referred to or their family is, the more they need to deal with something like transportation. Wait lists is a huge one, having problems with insurance. Distrust of medical professionals is also highly endorsed in this sample. Not knowing who to call, right, and how to problem solve, who's the right person. A lot of times families are dealing with all different types of providers and, should I talk to my social worker, child welfare worker, probation, for example. Cost, worried that their child might be taken, right, can be a big barrier to people engaging in treatment. What if they find something and then that's a new charge, or, this could actually cause problems, and it does for some families. Feeling embarrassed, and not having access to services, right? And this can happen in both urban and rural areas. And finally, childcare issues, right? Just basic logistics. Okay. All right, so I'm going to focus now on implementation. So again, you've identified an evidence-based practice for treatment, and why is implementation so important? So a lot of the research studies that make something an evidence-based practice happen in very structured, controlled environments, right? Because it's research, and we're very we have to do all of this the exact same way, measured exact same way, but we know that doesn't really work in the real world, right? So while it's important to look and see what the evidence base is, we need to think about how that works in actual practice. So I have a couple of examples of where implementation has been shown to be, really important to show actual effects in the real world. So Gina Vincent and colleagues, they did this research in Caddo Parish in Louisiana, and they looked at implementation of risk assessment using the SAVERY and then case planning based on identified treatment needs before any implementation training had happened. And they basically found that even though they were using an evidence-based tool, evidence-based practice, they weren't seeing better outcomes in their jurisdiction. And so Gina Vincent and her team had a very intensive training and implementation support plan, including in-person trainings for several days, going through actual case plans, giving feedback, giving support, helping come up with a service matrix, right, for what are the different referrals that should be made based on treatment needs, and then a booster training 6 months later. And they found with good implementation, they were able to reduce placement by 50%. The kids who had the maximum level of supervision in the community decreased by 30%, and also the use of unneeded services. So they were referring fewer kids to services who didn't need them, whereas the high-risk kids were actually getting connected to more services. So another example, and there are a lot, but another example is treatment. So let's say you get a kid connected to treatment. Landenberger and Lipsey, they did another meta-analysis looking at, I think, 58 studies, and they found that like CBT was effective, cognitive behavioral therapy, was effective in reducing recidivism, but only when there's a really high level of fidelity with those clinicians. So in order to improve implementation success in your jurisdiction, there have been some factors that have been associated with success in different jurisdictions. So we're going to highlight some of those from Sarah Walker. First, selection. So thinking about what types of needs you see in your clientele, right, and what types of services are needed is really important. And then, are there any known interventions to address them? So using some strategies like the tool that Joe highlighted to find evidence-based practices, for example. Next is fit. So does this intervention fit your needs in your jurisdiction and for the kids that you're trying to serve? And are there any adaptations that need to be made? And then finally, ongoing data collection to see, is this intervention actually achieving what we want it to do, right? And so collecting data at the beginning and on an ongoing basis, early and often, to make sure that you're saying, do we need to continue to adapt this? Is this actually working? Do we need some more support with implementation? So now we're going to sort of keep those in mind, the selection, fit, and impact, because we're going to highlight some of our projects now and how we've tried to consider those in some of our research.
So when Evan's talking about implementation, right, it's really how do you take an intervention or approach that's been studied in research and make it work in your local setting. And so for us, we're based in San Francisco, and so we do a lot of work with folks in San Francisco County as well as kind of the East Bay Area. But so I'm going to highlight 3 different ongoing projects that we have that tackle slightly different mental health and substance use needs for related but slightly distinct groups of kids. So the first is our family telehealth project. So before COVID, we were doing a lot of work with the San Francisco Human Services Agency, HSA, trying to understand where teens were getting placed. And what they told us is that the vast majority of teens from San Francisco were being sent out of county, so far away from their families. And this was before telehealth was considered kind of common practice and acceptable, right? So there was this question of, how are families being engaged when kids are being sent from San Francisco down to an STRTP in San Bernardino, right? That's a really far away. What are you doing? It's just taking the kid out of their home, right? And so we talked with stakeholders in San Francisco and then actually in placements where kids were going out of county to understand what are they doing in terms of family practices within therapy. And we found that in a lot of places, families were maybe being involved in phone calls or an occasional visit while a kid was there for 6 months to a year, not involved in structured treatment in most cases, right? Because distance is a huge barrier. And we know that a lot of these kids have really significant mental health and substance use treatment needs, and that involving family is part of what makes treatment more effective. And so we came up with the Family Telehealth Project intervention. So this is how we selected our need, right? So stakeholder driven, and then got money to actually develop and do this program. So what we did is we took an intervention that was developed with adolescents in the juvenile drug court in Rhode Island. And it's a family-based treatment. It teaches emotion regulation skills, so how do you manage your feelings? It teaches communication skills, so how do you help parents and teens talk to one another in a more effective way, right, and manage high conflict type conversations. And so what it is they learn these skills separately, so they each get an individual clinician. They learn the same skills, and then they come together and they practice together in family sessions. And for a lot of teens, this is actually pretty cool because often they're told that they're the problem, and it's like, oh, you're actually teaching my caregiver these same things, and then they can see and work it out together with coaching from a clinician. So in the research trial, they found that it actually did help improve family dynamics, and it helped with adolescent substance use, so reducing cannabis use. So really promising in that kind of a setting, but this was in person, and we needed to make it work for families who were at a distance. So we worked with stakeholders in San Francisco across probation, across HSA, for folks from the courts. So judges were coming to the table, people from the schools. So really a lot of leaders coming in, looking at the actual content of the intervention session by session with us. And figuring out what did we need to consider to make this work for the young people coming from San Francisco. So they raised a lot of important issues, but at the core, it's actually a brief intervention. So we do an engagement session where we're getting buy-in from teens and the caregivers, and then we have 4 core sessions. Each of those include an individual and a family component, and then we do a booster session a month later to check in about how things are going and reinforce progress. So some of the topics that were really emphasized in the research study were around substance use, which is of course relevant for teens in foster care, right, who are coming from juvenile court. Healthy relationships, also really important, is what we know. And then also about HIV risk behavior and sexual health. And then also about trauma, right? We know there's a lot of history of trauma for basically every single kid in foster care, right? There's really some history, even if it's disruption of placement, attachment, history of abuse, right? Really wide ranging. So those are some core concepts that we built in and maintained from the original study. And these were just some other things that stakeholders said you really need to make sure you're addressing, right? Barriers that we know to treatment are the distance between families, transportation to get people to an office, issues with insurance and reimbursement, engagement, and then having providers and disruption. When you're taking a kid, moving them out of county, they can't maintain their same relationship. So what they talked about was like, how do we keep kids engaged on a screen, right? We don't think that a kid's gonna sit in front of a computer and do a therapy session, right? So all of these were pre-COVID, and then had to really quickly make this happen when COVID hit. And we found that they will, in fact, sit in front of a screen, as I'm sure that you've seen, right? They had to do it for a lot of things. We had to make some modifications in terms of session length, make activities more engaging, right? In person, we were doing activities that included like teaching condom skills, right? And doing condom relay races. And you can't really do that over telehealth, but can do other activities that are still fun and engaging. So that's how we took kind of that input to make the intervention happen. And so what we've also done is really take family feedback into account. So we got family feedback from actually that initial study that our group did in Rhode Island. So we knew that they liked the intervention content. We knew the skills were helpful. But then we needed to know, okay, over telehealth, is this still helpful? And so we did an initial kind of test of the intervention with families. And Evan will share some of that feedback, but I just want to kind of speak to the other piece that became really important was we found that a lot of caregivers, so kinship caregivers and foster caregivers, wanted to learn these skills too. And sometimes a teen didn't want to participate because they had a lot of other treatment providers and they just didn't want to do another thing. So we also made a version of the intervention where caregivers can participate on their own. So even if the teen's not willing, this is a service that the caregiver can engage in on their own, and we're seeing a lot of promising impact from that as well.
All right, we had other slides, although for time we decided to focus on some of the quotes because I feel like it was really illustrative. And as was pointed out in the talk this morning, right, data is helpful and stories provide a different picture. So just want to highlight some of these direct quotes from families. So I think this is awesome. Give me more communication skills and insight on growing and maturing teens, right? So psychoeducation about teens and how they're developing. I won't read all of them. I'll give you a second just to read through some of those.
Maybe translate them.
And then I'll translate the Spanish one. So I liked that I participated in this role with my youth, and I liked that I understood the perspective of my son. And the last one is I liked it a lot, and it helped me act differently in the situation. So far we've had 100% satisfaction ratings. People feeling like it's really, really helpful. 0 to 5, it's like 4.9, something like that. So there's your quantitative data.
And so Yeah, and so as you can see, though, from the quotes, we do also offer the intervention in Spanish, and we're doing work to culturally adapt the skills to make sure that it is responsive to the needs of Spanish-speaking families. Many of the caregivers are immigrants. Many have not lived in the U.S. for a very long period of time. Some have, but so there are also issues related to an acculturation gap between caregivers and their teens, and so getting them on the same page around communication can be really important. I know that many of you took flyers. So we have flyers that if you actually want to refer youth or caregivers that you work with to these services, you're welcome to. And so you've got a flyer for this one, the Family Telehealth Project. I want to also talk a little bit more about how we're leveraging technology, right? So we've talked about how we're doing this therapy session over telehealth, but we're also doing some work with designing apps with young people and with caregivers. So there's this approach that's called participatory informatics, which is super jargony, but it basically means it's folks who don't have technology experience coming together and helping to design technology tools that are meeting their needs and that they can use. And so there are actually platforms out there that people can design workable apps without having to code. It's almost like point and click, like building a PowerPoint. So a little bit of tech skills in terms of that, but really not complicated. And we've been able to build some really cool products with young people. So part of this idea is that there's this digital divide that we talk about a lot with who has access to technology, right? We think about who has devices, who has Wi-Fi, but there's also this divide in terms of who actually helps to design or create the tools that we have. And if you're not part of the design and your demographic or your group is not contributing to that, then you often get left out in terms of what technology exists, right? So there's really even basic things, like if you think about apps on your phone, like games, so like Pokemon Go became really popular for a period of time. And so there's this thing where they have like these Pokestops that you spin and you get little prizes. And they found in the beginning that they were only showing up in really affluent, predominantly white neighborhoods, right? And that's not because non-white kids don't want to play this game, right? It's just because they were not involved in the design, so they weren't making it onto the map. So they're getting left out in that really basic game way. But the same comes into play with mental health. So who creates tools matters. So I want to talk about Foster Space, which is a project that we have been working on with transitional age youth in foster care in the San Francisco Bay Area. And so what they have done is they have helped design a mental health and substance use service navigation platform on an app. And it's really designed to take the stigma out of accessing resources and to make care accessible for every youth at the moment that they need it. So I'm going to show you a little demo video of what this app does that explains it more simply than I can, and then a testimonial from one of the youth who helped to co-design this app.
Welcome to Foster Space, an app tailored to your mental health and wellness needs. Foster Space was co-designed in collaboration with our Foster Space Advisory Board. The FAB is made up of Bay Area foster youth who are passionate about empowering their community by making it easier to find and access the resources they need to flourish. With Foster Space, you can take charge of your mental wellness. Keep track of your mood with the Foster Space Daily Mood Tracker. Take an emotional wellness assessment so our clinical team can provide support based on your needs. Or check out our catalog of wellness resources carefully selected by our Foster Space peer co-designers and UCSF care team. Foster Space is here for you. Just reach out to us via the Foster Space chat function, and a member of our team will be available to answer your questions. Find helpful resources in your community. If local resources are what you're looking for, Foster Space has you covered. Search county-specific resources by service need. Personalize your list further by using the like function. And as always, you can reach out to one of our navigators for questions about available resources. Organize and set personal goals. As a Foster Space user, you can create missions to help achieve your personal goals. Feeling stuck? Reach out to a foster space care team for additional support creating missions. Registering for the app is easy, and we have your back if you have any questions. Register today at fosterspace.com and learn more at
All right, so as you hopefully gathered from that, it's an app, but it also has live clinicians that are part of it. So we have licensed mental health therapists who can provide mental health and substance use treatment. We also have a navigator. So this is a trained person who can help young people to access resources in their community, and it can be for anything. So mental health and well-being is defined broadly, right? This is making sure your educational needs are met, that you're able to have stable housing, have a job if you want it, just kind of meet any vocational things that you are looking for. And so young people can go to this app and they can browse things on their own. So if they know that they want resources to apply to college and they don't want to talk to anyone, that's okay. They can go in and they can look in the database and find it. If they want help with it, that's available to them too. So it's really about getting young people right care at that right time. So this is a testimonial video from one of our co-designers.
I've been in the foster system since I was about 6 years old. And fortunately, I wasn't alone. I had my 3 other siblings with me. Obviously there's other people who aren't fortunate to have siblings, or have someone, a best friend, to really just be there through that hard times in their lives. But with this app, the goal is to provide that, whether it's a fellow foster youth or a clinician or a navigator, just someone to share their life with in a way and kind of find purpose and meaning in that. And so one thing that I really want to emphasize through this app is just that your trauma does not define you, Life is hard, but there are so many ways to make life a little bit easier. And with this app, it's definitely made my life a little bit easier, just to know that there are others in my community who have been through similar, events and, have struggled with mental health. I really just want to make a community out of this and let other foster youth know that they're not alone in this and that they have a voice. And yeah, it's been great.
So right now, foster space is available for transition age youth who either are currently in extended foster care or were previously involved in the foster care system. This can include through being in placement for part of the juvenile justice system. And it's for Bay Area counties only right now, though we're looking to expand, and 18 to 26 is the age range. So you do also have a flyer if you think this is something a young person that you serve might benefit from. With this project, we're really continuing to build out this app and the service. And so one thing that the young people are really saying is that they want a peer component to it. So they want to be able to connect with each other and provide peer support. And so that's kind of the next step in this work, is really getting them trained to provide peer navigation and peer support and to work within the app and within the care team. So I'm going to talk about one more project. So this is Project Raise, and this is actually for caregivers whose teens are in juvenile hall. And so one thing that we know is that being separated from your child can be an incredibly stressful experience for a caregiver, right? A lot of caregivers don't feel like they know how to navigate the system or that they get the support that they need. And then when the youth is in the hall, often it can be hard to have communication with caregivers for a lot of different reasons. And family involvement in care is not consistent across counties, right? Sometimes it's better than others, but then we saw a lot with COVID that there were disruptions to family visitation and to involvement with caregivers not being able to come because of safety concerns, right, with health. And so we are designing with caregivers and have designed this platform to help caregivers learn how to manage their own stress during this period of time. And so this, again, was from a need that caregivers identified, is that they needed a tool to learn how to manage their own stress better. And so we know that caregiver stress is actually linked to teen outcomes. And so when caregivers are experiencing higher levels of stress, they have a harder time helping their youth to engage in treatment that they need. And youth are actually less successful in treatment. But a lot of times we're not teaching caregivers or attending to their emotional well-being needs because they're not considered the patient, right? And so if we're not looking at the family's whole needs, it can be harder for youth to be successful. So that's where Project RAISE came from. It's this idea that if we can help parents to manage stress during this period of separation, that they'll be better able to support their youth as they're reentering the community and to get them linked to care that they need, because we know that reentry can be really challenging for youth. It's a really critical window when a lot of youth don't end up getting into community services that they need. So again, same kind of platform that we're developing with caregivers. And so these are just a couple of screenshots from it. So it teaches caregivers, though, what is stress, how do you manage it, and different techniques around that. And so happy to answer more questions about it, but just wanted to highlight kind of our continuum that's going from using video-based technology to do mental health or substance use related sessions, having apps that complement care, and then actually just standalone apps that folks can use on their own, because we know it can be really hard to show up to an appointment, even if it's just because it's at a scheduled time and your work schedule changes, or you've got children you're juggling, or you only have a few minutes, but you want to learn something new. So trying to really use technology to help meet lots of different needs. So that said, we would love to have a discussion with all of you, which I know is a little bit challenging, but hopefully this will work out. So we'd actually like you to turn to your neighbor or to a person next to you who maybe you don't know, hopefully from a different county. If it's someone you know, that's okay too. But we would love to get you to just take a few minutes and think about those kind of implementation questions that Evan brought up earlier. So just take a minute and think about, what are your county's needs to serve justice-involved youth who are getting placed into foster care? And are there interventions that you're aware of or not that can fit those needs? And then how would you go about adapting an intervention if you found it, or if you've got one that you're already in the process of working towards? And how might you know if it's actually helping these young people that you're serving? So we'll just ask you to take a few minutes and talk with your neighbor, and then if anyone is willing to share, we would love to hear what you're thinking about or what you're already doing. And in the meantime, if you have questions on cards, we're happy to take a look at them and answer them. So take a few minutes, maybe 5. All right, I hate to interrupt the conversations, but for time, we'll ask everyone to come back. Is anyone willing to share kind of what they talked about? Or any part of kind of it? You don't have to answer all of the questions, but we'd just love to hear about kind of what your area is thinking about or what the needs are.
And we've been reminded to please speak up because we don't have microphones if you are willing to share.
Yeah, thank you.
So I currently work for the CPOC. Back 2 years ago, I was a CPS social worker, as a primary social worker for the pilot program for CPOC in Sacramento County in the East. And the needs at that time were, we had a high level of substance abuse. I would try to gather a fit team for my, and it's not this kind of fit, it is family intensive therapy. Because most of the youth were more successful, as you've already stated, with families on board. And we met usually based on, most of my youth stuck around. I would say did not really a wall. And most of them, of course, were involved in the juvenile justice system. However, most of them were not placed in California. A number of them were placed in Florida, Pennsylvania, Georgia, Texas, based on primarily their substance abuse and then their mental health and then a host of other issues, including prior starting or any of those things. there were issues with placement based on those things oftentimes in California. Except for, okay, so I just have to say this. So I ran into Casa Pacifica. They're going to be speaking too. They're amazing. I had really, really great results with some of my kids that nobody wanted to case manage. So I will, and that's just been very useful. I would say that at that time, and I don't know what is going on now with the cases, Sacramento County did not do the absolute best job in substance abuse management because they were trying to tackle safety and then mental health issues. And yes, some of that goes along with substance abuse because most people don't use substances without having mental health issues. But we were kind of all scrambling and there were no best practices because it was a pilot program.
Yeah. Thank you so much for sharing that. Anybody else?
So one thing we talked about was like one of our frustrations, because I'm not sure how it is in other counties, but with us, we're still dealing with pretty much all the agencies in our county. They're still doing everything through Zoom. And it's just frustrating because like I have kids who are missing appointments, and the problem is they put too much responsibility on these kids to figure out the Zoom stuff. Like I have a 13-year-old who missed multiple sessions because she expects the 13-year-old to figure out how to work the computer, let the teacher know, and to be able to go and set it all up to make the appointments. But before, she never missed an appointment because she would go to school and she would pull them. And it's just like, I don't know, it's just like technically he's not doing what he's supposed to, but I don't really blame him. But you can't force these other agencies to see them. I just think it's funny that before the same therapist would say each kid has an individualized plan, not all the same. And then when you bring it up to her, she's like, well, I can't really do that. I got all these other kids. And I was like, dude, just, I don't know, like, it's a little frustrating because they need to address these things. And I'm not a professional in substance abuse or mental health, but people that aren't really working with you and these kids, and I don't know, what do you do?
So collaborating across as like a behavioral health and substance use is really challenging, right? I feel like that's a common thing we hear is these sort of, what do they say, like they're siloed, right? You're dealing with the same kids and families, but all these different systems, and yeah. And you also spoke to the implementation, right? You have an individualized plan. Maybe there's a rule that says you have to have that or something, but then what does that actually look like? What's the paperwork look like versus what's actually happening in practice? Yeah.
Yeah. Yeah, absolutely, right? And that can be exhausting to keep chasing people down, but you're right, you can't expect a 13-year-old to figure all of this out on their own. And that's also where technology doesn't work for every single kid and for every single situation or every single need, right? And I think before COVID, we were doing a lot more of meeting kids where they were at, and then we've locked down for a lot of really good reasons, and also mental health and substance use are really crucial to be addressing and just as important as addressing physical health needs. And so there are times where you need to be showing up in person, right, and doing that work.
Any other comments or thoughts, things you learned in your discussion with your neighbors? Anybody you'd like to share? No? All right, well, sound like you had some great discussions. Should we do a couple questions? Okay. One question, and as I was saying this, I was like, too many acronyms probably. It's a really long one. One question was, what is OJJDP? And that is the federal agency that is in charge of juvenile justice. And so it stands for Office of Juvenile Justice and Delinquency Prevention. And I believe it was first enacted in 1974 at the federal level, and then it's been renewed several times. So it's also a place where you can go find resources and go find, see what types of research is being done, right? They actively fund research, and also you can get resources around evidence-based practice. Another question was, great question, are there additional barriers for rural youth? And there are. And so just want to highlight some that we highlighted from other studies that we've read and things like that. One is a lack of specialized treatment, right? If you're in a rural community, you can't a lot of times there's not the same variety of specialized treatment for kids. And as we talked about, it's really important to have individualized treatment to identify what those treatment needs are and then get them connected. There can also be, depending, more under-resourced areas. A lot of times families might be more likely to be facing poverty, or there's fewer dollars to fund some of those treatment providers, for example. Distance, right? And so for families getting to treatment, it can be, right, they got to build in more time to drive and get there if they have transportation. So it can be a lack of public transportation. So as I said, fewer providers. And then finally, culturally responsive treatment. And for example, families who don't speak English and don't have that ability. That can be rare and hard to find even in cities like more urban areas, but especially rare in rural areas. And I'm sure there's others that I've missed. But yeah.
Okay, we've got two other questions here, and if there are others, just if you hold up your card, we'll come get it. So one was, is there any cost for the foster youth to access foster space and its services? So no, it's all of the things that we presented are completely free. We don't bill insurance, they're just free services. They're funded through either government grants or private donors, and we can talk a little bit more about that, but totally free to the young people and the families. Are there specific eligibility areas or other criteria for Project RAISE? So for that particular project, that's for anyone who's a caregiver, doesn't have to be a parent of an adolescent, ages 12 to 18, who has been in juvenile hall or is in juvenile hall right now or in the past year. And we're specifically trying to serve caregivers whose teens have used substances, so they don't have to have problematic substance use. It could just be experimentation, but in particular, trying to reach that group of folks. And for that one, it's only in English, unfortunately. Yeah.
Is that one for this, or is it already running?
That is for that. So we are finishing up kind of this co-design process with the caregivers. So we're still taking a couple more folks to give feedback on it, and then we're rolling it out as just a service available. So yes, that's that flyer that you held up though. And that can be anywhere, so no jurisdictional requirements there.
Any other questions? All right, here's our contact information. If you have any questions or anything we presented on, or if anything that you just like to, chat about, please reach out. We love to learn more about what y'all are doing across the state, and thanks for having us.
Thanks.
Thank you, Dr. Holloway and Dr. Fulk. We appreciate that. It was a great presentation. Just a reminder, the index cards at the end of your tables, if you have questions, go ahead and write your questions on those index cards, and I'll come by and scoop those up from you. So our next presenters are from Casa Pacifica. So we have Shauna Morris. Excuse me, I didn't bring my glasses up here with me. So Shauna Morris is a native of Kansas who earned her MPA at the University of Kansas. Since joining Casa Pacifica in 2020 in the midst of COVID pandemic, she has successfully led the organization through a strategic planning process that focused the agency on meeting the growing needs of the local communities. Her commitment to ensuring access to education, prevention, and mental health services is fueled by her life experience of being a child of an addict. Her daily mission is to reduce the pain and suffering of those suffering from mental illness. Prior to joining Casa Pacifica, she was a senior vice president and chief operating officer at Menninger Clinic for 18 years before taking over as president and CEO of the Phoenix House in California and Texas for 4 years. The clinic is an internationally known psychiatric hospital that treats adults and adolescents with complex mental health and illnesses, and Phoenix House is a nonprofit that is a nationally recognized and accredited behavioral health care provider, specializing in the treatment and prevention of substance use disorders and co-occurring substance use and mental health disorders. She is a half marathon and marathon runner. Right on, I love it. And can be found running the hills and streets of Simi Valley in the early morning, along with her husband Andrew and their 2 Labrador pups. Okay, and then we have our other speakers, Peter Gelber. Peter is currently a recovery specialist for Casa Pacifica, located in Camarillo, California. He has been in the substance abuse and recovery field for over 32 years. Peter has had extensive experience working with friends and families of addicts, helping them by utilizing the Alcoholics Anonymous model. Currently, Peter is facilitating youth groups in the field of addiction, utilizing the 12-step program along with Matrix model. Peter also meets with the clients individually to offer one-on-one support. He co-facilitates a weekly parent group. The group provides each other support while learning interventions focused on DBT skills and positive parenting. Peter provides the family members experience, strength, and hope, and also works individually with family members, providing peer-to-peer support to families. So thank you, Peter and Shauna. The floor is yours.
Am I the luckiest person in the world that I get you at 3:45 on Monday? I kind of feel like we need to get up and do jumping jacks or something to kind of get our blood flowing. But all right. Well, thank you so much for coming in today and talk about something that's near and dear to my heart, and that is about how we can provide services for the kids in our care and their families. So I'm going to talk just a little bit about who Casa Pacifica is. And then I'll pay my paid advertiser back here. So your check's in the mail. Thank you so much for that. And then tell you a little bit about what's going on at the campus now and what we're seeing with the kids that we're serving. And then you're going to hear some really great stuff from Peter. Sound good? All right. So here's who Casa Pacifica is, and I'm just going to tell you, just give you a couple quick facts about it, because some of you may have heard of Casa Pacifica. Maybe some of your kids have been with us. We've been around for 26 years, really doing a wide variety of work with kids and families. We are based in Camarillo. We do a lot of work in the Santa Barbara County as well as Ventura County, and then we do serve kids from all over the state in our residential program. About every 4 hours, a youth is admitted into one of our programs. That's a lot of kids. We do a lot of work with safety in the Santa Barbara County, which means we go out on safety call when the calls come in. The other interesting fact is that only about 20% of the work that we do is currently being done on our campus. It's a big, beautiful campus, but we're really out in the community, and that's really where we can do our best work, right? With all the changes in the state, the focus has really been in getting us out in the community, and we're so happy to tell you that we're out and about. Most of our staff are in homes, they're in schools, they're out where the kids are, working hard to keep them from having to be put into placement in our campus. We serve about 400 youth and their families every day across those 2 counties and across the state. 62% of the youth that are admitted into our program use, abuse, or are dependent on substances. That's going to be a really interesting point as you think about what we're going to talk about in a minute, because 62% of the kids that we see use, abuse, or are addicted. We do measure. We try to figure out if the work that we're doing is working, and so we do set goals. We do measure those goals, and we've set some high marks for ourselves, and I think we're doing a really good job. We know about 89% of the kids that we serve reach their treatment goals, and that's a pretty good mark. Oftentimes I'm asked, how often do you follow them after treatment? Sometimes we get to follow up with them if we can find them, if we keep track of them. We do a pretty good job of following up with that, and we found out that the treatment is sticky, as I call it, and that means that they have not been, we've not reoffended, have not been back into the trouble that they've been with before they came to us. And we also know that a lot of people, most of the kids that come to us and their families would refer to us. So that we hold those as high marks, and we continue to look at that. And just lastly, very important, all of our programs are nationally accredited, so that helps us also because it's good to know that we're holding up to what we're saying we're doing. I don't expect you to read this slide, but I want you to look at it. This is a problem. This is a huge issue for us. Publicly funded kids have way better access to services than privately funded kids. Isn't that funny? We would actually think it's just the opposite. But about 10 years ago, we started working with kids that have insurance as well. And what we found out is it's very limited. It's very restricted. And so I just showed this slide to show you how that we still have a lot of work to do in our field, is to make sure that kids that are, it doesn't matter how you're funded, that you can get the services that you need. And plus, we do a lot of work, right? That's a lot of programs to keep track of. Earlier today, I was sitting with our colleagues here, and we were talking about what all these words mean. And I said, yeah, with the world that we live in, it just means you take a lot of care of a lot of kids, right? So that's what it is. So here's where we're at today. These are the facts. The facts are that after COVID, drug use went down, but deaths went up. And why is that? Because the opioids are a lot stronger. Because the drugs that the kids have access to are a lot stronger. We saw an interesting thing happen on our campus. We have a couple STRTP programs, and then we have some private insurance programs as well. And during as soon as probably about a year into COVID, what we started to see is this outbreak of triple Cs on our campus. And triple Cs sound like it's really exciting, and if you know what that means, it basically means it's quercetin, cough, and cold medicine. It is so easily available. Think about it, it's COVID. Nobody feels great if you're getting COVID, you think you're gonna have it. They put all that cough medicine right in the front. All you had to do is walk into any store. It didn't matter if it was a Target, a Walmart, a drugstore, a gas station. They were selling these drugs, and they had them right front and center. Our kids would go in and grab a couple boxes of them, and do you know what happens if you take about 20 of those? You start having hallucinations. You are out of your mind. You feel so good. And then it starts to wear off. And about 4 hours later, you don't feel that great anymore, so you take some more. Except for that stuff is stays in your system for 24 hours. And we started seeing kids take these drugs, and they kept taking them, and they would puck them, and they were hard to keep track of them all, but they would just take them and take them and take them. Oh, and it's full of acetaminophen, and you know what that does to your liver? Yeah. So one afternoon, we had to life flight a youth to UCLA to get a new liver because she had taken way too many triple Cs. So while drug use might be down, the lethality of that is way up. And that makes it really scary for us as we're working with our kids. The other thing that's really a big challenge that we have right now and that we're working hard to fix, our colleagues talked about it a little bit earlier, and that's this whole idea about there's only one body and one mind and one brain. These children don't come to us with 2 or 3 different bodies and 2 or 3 different brains, and you can't say, oh, you have addiction, you need to go over here. I know you have mental health issues, you need to come over here. It's one person, one brain, one body, one child. And from a provider perspective, that is really, really difficult. You guys talked a little bit earlier about the training. And so many times we get our staff in and they've gone through great training, except for they've never been taught anything about addiction. And how is it that you can start working and taking care of kids that are using, abusing, and are addicted if you don't have that experience and you don't have those skills and you don't have the training that you need? And then you say, well, why aren't they trained? Well, I can tell you why. Because there's no funding for it. Earlier today, I was on a call and I found out that we put in our budget next year that we would like to have a substance use coordinator for our mental health contract, and the county called us and said, you gotta take it out. We don't pay for that. It's not their fault. we love our county providers, but there are two different buckets of funding in this state, and until we can get those buckets of funding to actually believe that it's one kid, one brain, one child, one body, we're going to continue to struggle. I'm so blessed that at Casa Pacifica, our generous donors allow us to have people like Peter on our teams, because without that, we can't bill for those services. And it doesn't mean it's not needed. It just means that we don't get to bill for it. So I will always be that hopeful person, and I will tell you that I have high hopes for Cal Ames and the work that's being done in our state right now to really start to think about a whole body and one person, one brain, one body, and being able to really give kids what they need at the time that they need it versus waiting for them to become very sick and then deciding which bucket do they come to and which side of their brain are we going to work on. So I'm very hopeful about that. And if you guys can help encourage your local communities and the decision makers that you work with every day, please, please, this is a good thing. We need to be able to get the funding right, guys, because it's one kid, one brain, one body, and they're suffering a lot. And finally, what we know is that the earlier a child is introduced into mind-altering chemicals, the more likely they are to end up with an addiction. And so at Casa Pacifica, we work really hard at this. And we think about all types of mind-altering substances. And so I'm going to go out here and guess that you might like sugar, because I had half a cookie before I came here because I need a little boost, right? Sugar, so addictive. Caffeine, so addictive. Nicotine, on and on it goes. And we try really hard to keep those substances in check with our kids. We try very hard to make sure that they don't vape. We don't want them to their brains to get exposed to that earlier than they already have. So we work very hard on that, and I encourage you guys to do the same. I know that marijuana is legal, but it is not good for these kids. It is not good for their little brains at any time to be using marijuana. And so we work really hard at Casa Pacifica to educate our kids and to let them know that, indeed, the longer they can keep all that junk out of their minds and out of their brains, the better it is for them. And then finally, I'm really happy that we do screen and assess every child that comes into our programs. And so there's a variety of different tools and screening tools out there, but at Casa Pacifica, we've decided to go with what we call CRAFT. And we do that because it's pretty easy to remember it, and it's held up, and it's been reviewed, and it's been the evidence-based, and we like it a lot. And so I'm going to tell you what it is, but I'm going to make sure I get it right, because it's kind of cool. So here's what it stands for. It stands for, have you ever ridden in a car driven by someone, including yourself, that was high or have been using drugs and alcohol? Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? Do you ever use alcohol or drugs while you're by yourself or alone? Do you ever forget things that you do while you were using drugs and alcohol? Do your family or friends ever tell you that you should cut down, stop using? And have you ever gotten into trouble when you're using drugs and alcohol? Those are really great ways for us to engage the youth as they come into our programs. And then, depending what their answers are, we go into a deeper dive. And we do use that to help us inform our care and our treatment plans. I was so excited earlier. I was writing down out of the 10 things that are good, and I think we're at about 8. I hope we are, maybe 7, but we're going to get there, and I love the fact that we got to learn from you guys about that again today. But that's what we do. Those are the tools that we use, that we have. We do that with all the kids that come into the campus and come into our programs, actually. Next off, you're going to hear from Peter, and he really is the star for the show today. Peter's going to tell you about what he's doing with Casa Pacifica, and I'm happy to say that some of these things made your list as well. A couple of them came off the clearinghouse. Most of them came off the clearinghouse. So it's just great. I was so excited when you guys were talking about that. And just so you all know, we did not work this out before. What they told you was their information. I met Evan via email or via Zoom for the first time on Thursday. But it's great to see that we are working together and we can learn from each other, and I really appreciate that. So anyway, here's Peter.
Hi, everybody. First off, I want to thank everyone, Sean and I, being asked to speak on such an important topic. The subject of substance abuse is near and dear to my heart based on personal experience. As was said, I'm currently working as a recovery specialist for Casa Pacifica, and I also work in the wraparound program as a parent partner. And wraparound supports at-risk youth and their families on an intensive level. So when Shauna asked me about presenting today, my immediate response was yes, not only because she's my boss, but it's really a subject that's near and dear to my heart. And speaking at conferences like this is daunting, but I never turn down an opportunity to speak on such an important topic. And again, thank you for this opportunity to share my experience, strength, and hope with all of you. I'm certain that many of you have been directly or indirectly affected by someone's substance abuse problem. An estimated 1 in 8 children lives with a parent who has had a substance abuse disorder in the past year. And according to Gallup, the effects of substance abuse are felt by around half of all American families. It's just an alarming statistic. You know, I've heard it said that the addict affects at least 10 people close to them, if not more. Personally, I am not an addict or a substance abuser, but I have been deeply affected by family members who have struggled with addiction. My personal recovery began in Al-Anon way back in 1990. For those who don't know, Al-Anon is a 12-step program for those whose lives have been touched by another substance abuse. It is an offshoot of Alcoholics Anonymous. And for the sake of simplification, we'll use the term substance abuse going forward to include alcoholism, addiction, drug issues, etc. My personal recovery began as I had no knowledge of substance abuse and couldn't understand why my loved ones couldn't stop. This did not occur in my family of origin. It happened later on. And in the late 1980s, a family member was drinking too much and causing havoc in their life, as well as our family. My family was going downhill fast. As a result, a therapist suggested I attend Al-Anon, as I was told I would get the support and answers that I was seeking. So when I began Al-Anon, I want you to hear this is important, the majority of members were spouses and children of alcoholics. Okay, now we fast forward to the last several years. The majority of parents, the majority are parents of children who use drugs. Very few seem to have alcohol as their number one addiction. You know, it's not only alcohol, but it's all the drugs that, are out there. So when I started, my estimation is that there were maybe 10% of members there for a child's drug use. Today, there's probably like 90%. That's how this problem has just increased. And today, there are many meetings that are called parent focus meetings, focusing specifically on the child's substance abuse and how it affects the family. This is startling to me. This conference is so important as a focus on our youth and substance abuse. It's so prevalent, and so many kids are dying and suffering the effects of these strong drugs that are out there, as Shauna had mentioned. The death toll from drug overdose during the first 6 months of 2021 was 53,000. 53,000. Now, I'm a big Dodger fan, right? I go to Dodger games, and the stadium, when it's full, holds about 53,000 people. And I just imagine at times, being just the people who have suffered from substance abuse, or even those who have tried it once, and, it's like the stadium's just cleared out. They're dead. It's just like, it's just shocking. And I have been to too many funerals for sons and daughters who have died as a result of an overdose. Probably in the last 2 or 3 years, there's 4 that come to mind, and I knew their fathers and mothers, and it's just the worst experience that a parent could have. I've held these parents when they've sobbed uncontrollably, and this is why this issue is so personally very deep. I've also witnessed miraculous successes with youth and their caretakers where their lives have turned for the better. So our focus also needs to be on prevention and early intervention. I got better as a result of Al-Anon and the support of others, and I understood addiction better and knew there was what I can do and what my part is in it. Even though my family member got sober, I stayed in recovery as a gateway to personal growth. And as time went on, I get to help others, and helping others is the essence of the 12 steps of AA, which I will discuss later. And I'm really grateful I stayed in this field because my son became afflicted with addiction, and I was better prepared for that roller coaster ride than I was the first time around. So being associated with the field of addiction has highlighted the importance of support groups as the most effective avenue to help parents and caretakers of children who have a problem with substance abuse. It's a very lonely disease. Parents, families don't want neighbors, don't want even other family members to know, because there's a lot of shame that is attached to this. But we know the AMA recognizes addiction as a disease. And a key for us parents and caretakers to help our children get substance free is by understanding ourselves and that the normal authoritative reaction is not going to work. A typical reaction, and I did this, by most would be to scold, punish, yell, shame, obsess, write contracts with them, and I've never seen a contract that's worked long term. You know, then we as caretakers, and I know I did this, I question my effectiveness. I blame myself. I feel guilty. You know, my son's an addict because it's my fault. You know, I could have done something different. And I get angry, and I came from a negative place, you know, and became hopeless. And this merry-go-round just continues and continues on. So this is such an important reason for educating the parents and caretakers, because we have to unlearn deep-seated beliefs and learn new ways of approaching the situation as do professionals. So there are a multitude of programs for youth in recovery, residential treatment centers, intensive outpatient programs, and drug diversion classes are prominent. These programs are helpful, but are we getting the desired results, long-term sobriety? We want to improve in this area, and we need to, and we must address the family unit. The breakdown of the family unit is a large part of youngsters getting involved with drugs. They are in pain, and they want the pain to go away. Things have to change at home for sobriety to be achieved, and both the youth and the caretaker need continuous support after leaving these programs as the battle to achieve sobriety is ongoing. Now, as I mentioned at the opening, and I am a recovery specialist with CASA, and we're doing the following. I work with youth struggling with substance abuse. I lead a weekly group focusing on relevant topics. And the topics include self-esteem, cravings, peer influences, parental pressure, effects of substance abuse on the body, specifically the brain and coping skills. So, you know, these topics are so relevant, and I want to hear from the kids. You know, I create really try to be as gentle as could be, non-judgmental. And, you know, there's just a few ground rules that are stated at the beginning of the meeting, and we do this weekly. We want them to be respectful, stay on topic, no glorification of drug use. Kids love to glorify, oh, I remember that I did this and that, and I was so wasted at school, and that we don't do that. We don't allow for that. And if the child is triggered during our meeting, speak up. And I encourage the youth to be supportive of one another. There is absolutely no shaming or blaming. I, along with other staff, create a safe and contained environment where the youth can feel free to discuss their struggles. And we focus on successes. I encourage them to share success stories. One young lady was recently so proud of herself because she was able to sustain sobriety during a difficult weekend of breaking up with a boyfriend. She shared how she utilized coping skills of listening to music, writing poetry, and having the self-esteem to stick to her decision. She mentioned that several times, and she was so proud of herself. She received great support and kudos from myself along with the group. So these occasions are opportunities to focus on positives, on the small feats that can lead to long-term success. I also meet weekly with the clients one-on-one. I come from the point of view of meeting them where they are at. We usually take a walk around beautiful campus at CASA. I want them to get outside where they get fresh air and exercise. During this time, at some point of the discussion, I focus on their interests. I love the outdoors, and for the most part, they do too. So many of our kids don't have healthy pursuits, or they cannot afford them. Most enjoy and some get excited when I point out the birds, the rabbits, clouds, trees, all nature has to offer. Their attitude changes, and we are able to establish rapport and trust. It works. I've had a few kids ask me to be their therapist, but I explain that is not my role. I'm here just to provide support and get to know them and be their advocate. And my role allows me to share on a more personal level. One area that is prevalent is the lack of older male role models in the youth's lives. It's sad when the boys in treatment don't have an older male to look up to. So I attempt to be that kind, yet firm, older role model. We had a client who was a 15-year-old male. He lived with his grandmother before coming to treatment. He had been to several treatment centers, and his parents, unfortunately, were out of his life. He was a difficult kid. He was in a lot of pain, and substance abuse was a very serious problem with him. He almost died twice, and just was overtaken by the drugs because he was in so much pain. He was reluctant to meet with me at first. I always meet them where they are out, and I use validation skills to engage them. I said, I get it. You don't want to talk to this old guy, but let's give it a shot. Let's go for a walk. And it happened to be the day after a rainstorm. Our campus is beautiful after a rainstorm. We saw hawks. The clouds were beautiful. He chased lizards, and for that hour, he was learning what isn't obvious to some until you make them aware, right? Our subsequent meetings were always outside. He couldn't wait to meet me. He learned to catch lizards, and we have a BMX bike course on our campus, and he ran that. He wanted to run that and have me time him, so it was really fun to get him involved in that, get his heart going, and he really tired himself out. He wasn't in the greatest of shape, but he had such a good time doing it. And every time I was timing him, and even if he was a little slower, I lied, and said, yeah, you improved by a second or two. He left us, and I think he left with an appreciation of nature, learned to trust an older male, and some good coping skills like running and hiking and a better sense of self. So at times we bring in a panel of young people who are sober and working in AA. It could be an AA-NA program. We utilize Ventura County Alcoholics Anonymous H&I program, and H&I is short for hospitals and institutions, and I'm sure they're available in all your counties. Obviously AA is, and we work closely with the H&I. And what's great is these young people are sober and eager to be of service. We screen them, we get to know them. There's always staff there when they come and talk and might conduct a meeting on campus. And this terrific service is free, but it's worth so much. It does cost us a few bucks to buy the pizzas, but you talk about low cost, no cost with priceless outcomes. I'm also part of a threesome that run a weekly parent support group dealing with substance abuse and also mental health. We bring varying qualifications to the group. One is a family clinician, and the other is our care coordinator. Our topics rotate weekly. And as said before, things must change at home, right, for the child to have some success for sobriety, enjoy better mental health, and an opportunity to thrive. Parents and caretakers learn the skills that are being taught to our youth. Topics include dialectics and mindfulness, validation, parenting, dialectics, and the principles of behavioralism, maintaining safety, crisis survival skills, which is really needed, radical acceptance, emotion regulation skills, and natural and logical consequences. Now we give each parent, each caretaker a notebook, so they could read that notebook, and it's made very clearly on what they do in times of a crisis, how to react. We try to teach them to respond, not react, right? And how use calming exercises so when they're in that tough situation with their child, they could take a step back and try to diffuse the situation. Our parent group coincides with the topics that the youth are working on. It's really important they speak the same language. We find it very helpful for the parents and youth to be working on the same criteria for that reason. And the parents can bring up topics that they struggle with, like social media, struggles over phones, and computer use, school struggles, etc. And one Saturday per month, this is one of my favorite days, one of the greatest things we do, is we host a family day called FEAT, Families Engaging Actively Together. The day comprises of fun and games for parents and kids to interact. We go on a hike, we'll hang at the beach, swim, serve lunch, and play games. And this is especially great for the kids in residential who don't get to see their parents and families much. We also include families in our outpatient programs if they want to attend. It's really heartwarming to be part of this activity. I get to meet the families visiting in person and watching the joy and some struggles, but mostly the actions are very positive. I now want to discuss the Alcoholics Anonymous model, which has been the most successful model of attaining sobriety. It's a community-based program that was created to help those with problematic drinking get sober with the support of peers. It's that simple. Many studies determine that AA was nearly always found to be more effective than psychotherapy in achieving abstinence. In addition, most studies show that AA participation lowered healthcare costs. Again, I'm including substance abuse here, not just drinking. Today, most AA members identify as addicts. They use more substances than just alcohol. But AA works because it's based on social interaction, members giving one another emotional support as well as practical tips to refrain from using. I've heard it said that if you want to change your behavior, find other people who are trying to make the same change. Sometimes it's difficult for professionals to admit that lay people who run AA groups do a better job of keeping people on the wagon, but that's just the truth. It's believed that counseling can be designed to facilitate engagement with AA. So a transition from intense therapy and counseling into the rooms of AA, where continued support can be achieved. And there are young people's meetings, so that's important for our youth to know and to possibly utilize. So I've seen the success of peer-to-peer interaction. It's benefited both the substance abuser and their loved ones in achieving sobriety. On a personal level, in Al-Anon, I got myself a sponsor who is someone in the program longer than me. They provided me with experience, strength, and hope, and gave me new interventions to solve baffling situations. I didn't know what to do, but there was someone who I could just call, and they were always there for me, and it was huge for me to understand what was going on with myself and to try new and more effective approaches in dealing with my son. It takes another addict, a sober one, to get an addict sober. They speak the same language, I'm so grateful to say that today my son has 9.5 years of sobriety, one day at a time. Oh, thank you. I'll tell him that he got a round of applause. And it really wasn't because anything I did. I listened to what I was supposed to do when he was in residential, and it was pretty much he was an adult, so it was stay the heck out and let these people who know what they're doing. Don't rescue him, don't come to his aid, don't enable him. But, he got sober, and he's in the field today because of the peer-to-peer model. And I also had a mentor to converse with, and our lives improved. And today, he's just a great kid, He and I talk on a very personal level, and, I get the language. I know what he suffers with. When he gets anxious, I get it. I don't try to talk him out of things, I want to hear what he has to say. And conversely, I share with him some important things. He didn't choose addiction. He just got stuck. It's a family disease, and, the gene was certainly passed down. This is pretty cool. I'll share this with you. Several months ago, he and I were asked to speak on a Zoom meeting in Moscow, Russia. When I asked my son if my son and I were willing to speak, when I was asked to speak in a group in Moscow, I thought they meant Moscow, Idaho. There was a Moscow, Idaho. I lived in Idaho, so I knew of it. And speaking to those people, obviously via Zoom, was incredible. And they spent about 45 minutes asking us questions. And it was touching because they're affected just like we are, And it's a drug addiction is a plague worldwide. And, I'm sure it's increasing. So peer-to-peer, it's a key. a simple and it's a cost-effective method that has historical evidence of being effective. Our wraparound program at Casa Pacifica, and I'm sure those who know about wraparound, are successful with great outcomes because we use peer-to-peer. I work with the parents and the caretakers, and then we have a family and child specialist who works directly with the youth. So as a parent partner, I utilize my experience to help parents and caretakers of at-risk youth. Peer-to-peer is non-threatening, and hearing someone speak from experience is real. And when they say, you don't know how bad it is, my general response is, yes, I do. You know, it draws them because I get it. I've been there. And it really widens that pathway of intimacy, communication, and trust. It's simple, yet it's really effective. And it's amazing to this day how desperately these caretakers want to talk to someone who gets it because they feel so alone. And as I mentioned, we also employ and wrap around the child and family specialist who works directly with the youth. The specialist provides the at-risk youth with someone to look up to, someone to provide the youth hope and tools for success. Again, the key here is peer-to-peer formats, someone who has experienced life struggles which help the youth develop trust, and a positive role model. In recovery, a well-known adage is it takes one addict to get another sober because they relate. And with caretakers and at-risk youth, it takes one who has been there to provide the way. A model that can be effective is utilizing the community to help these kids and caretakers. Al-Anon is one way. Other support groups for parents are needed, and Casa Pacifica has had them throughout the years, and the caretakers have told me they are very helpful. Several years ago, I watched a program on TV that featured a 10-year-old girl suffering from a brain tumor. She noticed a photo in the doctor's office of a female lacrosse player. She loved lacrosse. The girl walked by the photo on her many visits to the doctor's office. The doctor knew the coach of the lacrosse player. He reached out to the coach, who in turn called the girl's father. One thing led to another, and the girl, who had a long battle on her hands, was basically adopted by the team. So the 10-year-old met the team and had the support of every team member who would call, text, and support her through chemo, post-op chemo, and radiation. And a foundation was established to link other children with malignant brain tumors to college teams across the country. Today, many of these children benefit from this foundation. So, I wonder, why can't our counties adopt this model or a reasonable facsimile? What a great way to focus on substance abuse and mental health problems and our at-risk youth. It does take a village. So why can't our youth, be adopted by high school sports teams, college teams, church youth groups, and various organizations like Elk and Rotary clubs? It would be a low-cost, no-cost model that would have great results. Our youth need role models, mentors, and the support, as so many of them do feel so unwanted, unloved, and alone. And what a fantastic way for these students and those who give back to the community to be of service. If a probation youth has an interest in music, match them up with a mentor who has the same interest. We need to focus on the strengths of the youth who are constantly surrounded by negativity. I mentioned the young man I worked with who fell in love with nature. Currently, we're working with a female in our groups, and she's so interested in makeup and hair. Matching her with a mentor would make her so happy and would give her a positive path to pursue. So improving self-esteem and focusing on the strengths of our youth are the key to staying substance-free. I believe being of service to the community in some capacity is now a requirement for some of these kids to get into colleges. After all, being of service to others is a cornerstone to personal growth, and it does benefit all. And I have witnessed to see this model be successful with my son and other substance abuse problems, and myself and caretakers. So, I want to thank you all for letting me speak and for listening. I came from a more personal point of view, but, this is a personal thing. And I think when we could support our youth on that level and not be so clinical, but really meet them where they're at, it's going to benefit all. Thank you.
So the question is, what are your thoughts on children that report they have to smoke after no longer using hard drugs? We have a smoke-free campus, so it's really not an option to smoke on our campus. Having said that, we also have a medical team that will help the kids. We try to offer as many different ways for them to detox, step away from, replace. Peter talked about a lot of the work he does with the kids, but smoking really is not it's just not a choice that the kids have that live with us. Now, if they go off the campus, we don't know what they do. Sometimes they come back and they've smoked, but really we try to find other healthy alternatives for them, and it's part of their recovery process to not move from one drug of choice to the next drug of choice to another drug of choice. But I'm open to good suggestions from my research friends if you have other ones.
No, we definitely don't advocate for replacing one substance with another.